So, last time we started discussing about hospital industry and we discussed a little bit about the history of the hospital industry, and I told you I will not go into too much details about that, and also from your examination point of view I do not think I will have any questions that directly deals with the history of hospitals over the last century, but you should just give it a reading from your lecture note and kind of try to see what were the most important developments during each decade. Okay. So, in the current times the most important development in terms of the nature of the industry is, of course, the expansion of managed care and also the healthcare reform, the Obamacare, which we do not know for how long. Okay. Now, talking about hospital industry, today let us start talking about the classification of hospitals. Okay, hospitals in United States can be classified by three characteristics. First, the length of stay. Second, the ownership of the hospital. And third, the type of service that is offered. Those are the three criteria for categorizing hospitals in this industry. So, as far as length of stay is concerned, you can have two types. Some hospitals where the average length of stay is less than 30 days, and these are called the short term hospitals, and I am just putting it as ST, which means short term. So, if the average length of stay in a hospital overall is less than 30 days, those hospitals are called the short term hospitals, and of course, if it is greater than 30 days on an average, then those hospitals are called the long term hospitals. So, this is the most narrow categorization or the narrow classification of hospitals in United States. After that, you have classification by ownership, and as far as ownership is concerned, the hospitals may be divided into federal, non-federal, and I would like to put teaching hospitals here as well. Okay. Now, there are very few, these federal hospitals are very few in number, about 85 to 87 federal hospitals in United States. Among these are the hospitals, the non-federal hospitals are the ones which are maximum in number, and these non-federal hospitals once again can be split by the type of service that they offer, and the non-federal hospitals, by the type of service, they are categorized into community hospitals, and these are the major type of hospitals in USA, that community hospitals, and the specialty hospitals. Okay. Now, as far as the community hospitals are concerned, these are mostly the non-federal hospitals. They have shorter length of stay, so short term length of stay. They provide general services and they provide some specialized services. So, they will have some divisions like ENT, OBGYN, so on and so forth, but mostly they will concentrate on general services and they will have the important specialized divisions. But please note that they will not be focused on one kind of specialty. Okay. They will have all kind, even if they have the specialty units, they will have multiple specialty units. Okay. But when we are talking about these specialty hospitals, these are focusing on just one type. So, it is either going to be concentrating on urology, or it will be concentrating on respiratory diseases, or it will concentrate on orthopedic stuff. Okay. So, this is specialized just on one aspect, whereas in the community hospitals you will see general services and you will also see specialized or specialty units, but usually there will be multi specialty units. Okay. Now, as far as so I said this is the most important category of hospitals in USA, the community hospitals. Those are present in maximum numbers. Now, these community hospitals, once again, among these community hospitals, you have some hospitals which are private and not for profit. So, these are non-federal for sure, but here we are saying these are totally private and not for profit. That is the major share of community hospitals, about 60%. Okay. Then you have the private for profit hospitals, and then you have some which are owned by state or local governments. So, they are still government owned, but not the federal government, instead they are owned by the state or the local government, and that is about 25% and this is about 15%. Okay. This is among the community hospitals. Now, coming back here, that kind of gives you an idea about how the hospital industry in USA is classified. Now, as far as these community hospitals are concerned, I said this is the major category. Now, if you look over the years, if you research a little bit, if you Google a little bit, and I also gave you I think some data on these hospitals, the numbers and stuff like that. If you Google a little bit about the cost of these hospitals, you would see that over the years there has been a decline in the number of these hospitals. There has been a steady decline in the number of these hospitals, not just in terms of how many. Question? Community hospitals, yes. There has been a steady decline in the number of these community hospitals, and also among the existing ones, the ones which have not shut down, among those also there has been a decline in number of beds and occupancy rate, so on and so forth. So, there has been a decline in the absolute number of community hospitals, and also among the ones that are existing there has been a decline in the number of available beds and the occupancy rate. So, then what do you think is the reason? Number of patients of course is not going down, right, in USA. Demand is not going down. Okay, too costly. So then, right, so where are the people going then? Other hospitals, specialty hospitals, but they are not so many in number, right? So, where are those patients actually getting their treatment? ER, or in general there are more. Along with this, as you see, there is a decline in the number of community hospitals. During the same time period in USA, there is an increase in the number of the ambulatory care clinics, or basically the outpatient clinics. Okay. This is a different category. So, we are saying that these are not among hospitals at all. These are outpatient services. So, we are saying that if there is a decrease in the number of community hospitals, if there is decrease in the occupancy rate of community hospitals, then where are those patients going? Okay. So, it is observed that most of these patients who would otherwise go to a community hospital for something very small, not for an emergency or some kind of severe disease or condition, but some kind of minimal disease, they are getting transferred or they are getting treatment in these ambulatory care centers or in the outpatient care centers. Now, why do you think that is happening? That is happening because these care centers are mostly physician owned centers. They are either owned by one physician or mostly by a group of physicians. So, these are physician owned.
So, does that include ERs or
no? No. Does not. So, these are physician owned, and now you know from your principal agent problem that these physicians are the people who play a very important role in inducing the demand, right? So, if these are physician owned, there is vested interest of the physicians to direct the patients towards these centers rather than sending them to a hospital. So, the physicians can decide whether the patient should be sent to a hospital, and of course, like I said, for a very severe condition they would still be directed to hospitals, but for less severe conditions the physician has a vested interest in sending them to these clinics, right? And most of these clinics would require physician referral. Okay. So, now in the managed care setting, so all this is happening simultaneously, right. So, we said that the managed care is gaining popularity. During that same time the number of community hospitals is going down, and around the same time you are seeing the emergence of these outpatient clinics which are physician owned and they require the referral of physicians. So, what do you think? Do you see a link between managed care and here this? Right? In managed care we were talking about these things, right? We were saying that there is a primary care physician, there is a gatekeeper physician who would have to refer you to go to a specialist, right? And there is a vested interest, there is some negotiation taking place between the insurance company and these physicians who are in network, who are a part of the same organization. So, do you see an implicit linkage between the two, where these physicians have a vested interest within the managed care environment to direct the patients towards these clinics and hence kind of tweak or take advantage of the system, exploit the system in managed care? And that is precisely the reason that managed care, which was supposed to drive down the healthcare costs, has not been that successful, right? Had it been very successful, then we would not need something like a healthcare reform in 2008. The fact that the managed care was not able to achieve its primary objective of reducing the healthcare costs, that is why reform was necessary. So, this is one reason, because these are ways that the physicians were trying to exploit the system, that they were serving as gatekeepers, they were serving as a part of the organization, but they were also looking at their vested interest of referring patients towards clinics which were basically owned by these group of physicians. So, if you remember in your group model, that is what we said, they were a group of practicing physicians, right? And it is quite possible that maybe that group is owning a clinic like this, right. So, while they are part of the managed care, they are also owners of a clinic like this. What would they do? They would get a steady flow of patients through the managed care environment, and they would have incentive in redirecting these patients towards their own clinic. Now, coming to this part, so we said that under ownership you also have the federal, besides the federal and the non-federal hospitals, you also have the teaching hospitals. Now, after the community hospitals, these are the most important type of hospitals in USA, the teaching hospitals. So, about 20% of hospitals in USA come under this category. And as far as the ownership of these hospitals are concerned, these are usually affiliated to a university, the teaching hospitals. So, they will be some kind of medical, they are med schools basically, which are affiliated to universities, and what qualifies them as a teaching hospital is they must have one of the 4 residency programs which are approved in United States. I think it is the American Medical Association probably which approves the residency programs. So, one of the 4 residency programs that are approved in United States, they must have one or more of those programs running in them. That qualifies them as teaching hospitals. Now, around the same time, that is in the managed care setting, when there was a decline in the number of community hospitals, on the contrary, there was an increase in the number of these teaching hospitals. Okay. And if you compare between the teaching hospitals and these community hospitals, these teaching hospitals usually have a higher average length of stay. So, these are long term hospitals when you compare them to community hospitals. Yes.
You said at the time that the community hospitals were going.
At the same time, when the community hospitals were decreasing in number, there was an increase, there was a small increase in the number of teaching hospitals and quite a significant increase in the occupancy rate and the number of beds in those hospitals. Okay? That is something that has been observed. Now, what are the characteristics of these teaching hospitals? First, I told you these are usually, compared to community hospitals, these are long-term hospitals. So, they have longer length of stay. And another most striking feature is, compared to community hospital, they have very high costs of operation. Please note, by cost I am not referring to price. I am talking about the cost of operating the hospital. Very high cost of operation. Why do you think that the teaching hospitals will have very high cost of operation? Okay. So, that means, what does that mean? That means they are having more, they are having a diversity in terms of the staff, right? They have more, they have to be staffed more. Compared to any regular community hospital, they usually employ more people. What else?
Liability.
What do you mean by liability?
Because you have, yeah, you
Hmm?
have residents that are doing procedures or whatever. And they're, dealing with residents. Like they're still learning. Is the idea.
Okay, so what do you mean by it? So, here we are talking about cost in the real terms, right? So, we are talking about, specifically talking about monetary cost. So, if they have,
You may go through more supplies if they don't know what they're doing. They break sterile field or they make mistakes. Or their malpractice insurance might be higher.
That litigation.
correct, there might be more litigation cases filed against these hospitals. There might be, like you said, these are people who are not so experienced. They have more people who are students, who are still in the process of becoming experts. So, it is quite possible that there are things that happen in those hospitals due to negligence or, you know, lack of expertise. So, there may be more litigation cases, etc., filed against these hospitals. So, that is also something that drives up the cost. Okay. But another most important feature which drives up the cost is, these hospitals are affiliated to universities. They are basically centers for granting degrees to future medical professionals, which means that they have very high costs, very high focus, and also associated costs on research, right? Most of the research takes place in these kind of hospitals. So, very high cost due to research. Then, like I said, since there is higher employment and many of these people are students, they have to pay stipends. Like you mentioned, more litigation cases filed. Okay, against these hospitals. And the more important thing, which kind of strikes out, so we said that these are hospitals which are usually the long-term hospitals, right? Besides that, these teaching hospitals are usually the ones which are located in metropolitan cities, or in other words, they are located in cities with a population greater than 1 million. Most of them. No, I will write more. I will just write that down. I will complete that point. So, they are located in cities which usually have a very high population. Most of these hospitals greater than 1 million. And not only that, they are located in the inner cities. What do I mean by inner city? Trump has made this so famous, inner city. In all his debate speeches, he keeps talking about inner city, inner city. What is inner city? Inner city is basically the central part of the city. It's the central part of any metropolitan city, okay, the core of the city basically. So, here in these kind of cities, if these hospitals are located in the inner city, they usually, like she said, that they usually cater to patients who are from underprivileged income backgrounds or economic backgrounds. Okay, or in other words, they are more likely to receive footfall from the uninsured patients or patients who cannot afford treatment at the hospital. So, they are likely to receive more uninsured patients or patients who are seeking free care. And all that I am saying, all that I am putting down here, there is no theory behind it. This is more empirical stuff that has been observed in USA. Okay? So, due to these primary reasons, the teaching hospitals usually have higher costs. Now, also please note, on the flip side, these are also hospitals which are owned or affiliated to a university, which means they have higher prospects of getting money from the government, because you know the government gives a lot of funds, it gives a lot of research grants to the universities, and obviously, you know, now that United States has so much focus on STEM, science, technology, engineering and math, those disciplines, in the recent times there is more funds that is kind of given to these teaching hospitals or to the medical schools which are affiliated to universities, right. So, those are those payments which are made by the government So, they receive money from the government and these government funds usually are in the direct form of research grants or some kind of aid, financial aid, but they are also in the indirect form and by indirect form I mean that these teaching hospitals usually have a higher reimbursement rate for the Medicare and the Medicaid patients. Okay. So, I just told you some time back that these teaching hospitals are located in the inner cities and so they are more likely to receive patients from the lower economic backgrounds, right, from the low income group, for people from the low income group. So, that means there is quite a possibility that they will receive more Medicaid beneficiaries, right, Medicaid is given to the lower income group. So, now if these hospitals, if the government gives them higher reimbursement rate, then that kind of compensates them. For the public insurance holders, higher reimbursement rate for the public health insurance holders, and by public health insurance I mean the Medicaid and the Medicare beneficiaries. Okay. Now, okay, Medicaid we understand, Medicaid is fine, that is directly about people who are in the low income group. What about Medicare? That is for the elderly people. Why do you think more elderly people go to the teaching hospitals, or in other words, why do you think more elderly people will go to a hospital that is located in a more populated place? What is the relation? What is PCP? Not really, that could happen anywhere, right? It is just about the demography. In United States, USA is a country that has a very high proportion of people who are Medicare eligible. That means very high proportion of people above 65 years of age. 1 out of every 7 Americans is above 65 years of age. So, population aging is a very serious problem in USA. So, proportionately, if a place has more population, then it will also have a bigger share of elderly people in that population, right? It is about a proportion, right? So, if you have in the entire population of the country, if you have more elderly people, then of course, if you go to a place which is more populous, usually it will be true. For some places it may not be true. For example, if you go to the west coast, then you see less proportion of elderly people, although it is a very populous place. But for most places in America, if the population is high, the proportion of the elderly people in that population is also high. So, you are likely to see more Medicare eligible people in the population within these metropolitan areas and in the inner cities of these metropolitan areas. Okay? Okay. Now, coming to the next part where we were talking about for profit and not for profit. Okay, before that let us talk about one point. So that's about the classification somewhat, and you can read more details in the lecture note about this. Now we have been talking so much about the market theory in economics, and we have been talking about the different kinds of markets. So you can understand this is an industry. So at the end of the day, there has to be some competition in this industry, right? So let's see what is the degree of competition in this industry or in this hospital market. Okay. Okay, so now from the discussion that we had about market theory and all that perfect competition, monopoly, monopolistic competition and all of that, do you think competition is necessary in any market? So, you said competition is necessary because it reduces inefficiency, right? And that is in line with what we kind of talked about last week. We said that if you have a perfectly competitive market, then that market is the most efficient one, right? It is a separate story that you cannot have a market which is absolutely perfect competition, because perfect competition is a hypothetical situation, right? So that means, but we can understand that if it is closest to perfect competition, or if there is a higher degree of competition in the market, then there will be more efficiency in the market. You agree with that? Right? Just based on what you know about perfect competition. We said perfect competition is the most perfect one. It has maximum degree of efficiency, and all other markets are less efficient than perfect competition, right? So that means, can we safely say that if we have a market that has higher degree of competition, then that market is likely to be a more efficient market than the one that does not have competition, right? And by efficiency, what do we mean? In economics, what do we mean by efficiency? And I am sure you have forgotten about this, because we talked about this, way back in lecture note 1. Given the resources, where utilizing the resources so that you can have the best that you can. And it is such a situation where after this, if you have to make somebody a little more happier, then you have to make somebody a little unhappy. Remember, to make someone better off, you will have to make someone worse off. So it's the best possible utilization of resources. So can we say that in this efficient system, the welfare is for everyone is the most optimum? Can we use the word welfare here, just to make it more, understandable in this setting? Because we have been talking about efficiency, but we don't really understand in terms of the hospital market, what do we mean by efficiency? By efficiency, we are trying to mean that if there is competition in a market, then that market is efficient, which means all economic agents in the market have the maximum possible welfare given the resources in that market. Everything is being optimized to the best possible, optimized in the best possible way, and people have maximum amount of happiness that is possible given the resources. And we are using another word for happiness, which is welfare. Basically as simple as that. Okay? Yeah.
You're saying the insurance providers and the patients that are getting the insurance?
No, here we are not talking about insurance at all. We are just talking about a market where there are hospitals. So the sellers in that market are the hospitals. The buyers in the market are the patients. Okay, we are just saying that is it good for this market to be competitive? That is what we are trying to say. Okay, so we are saying that irrespective of what kind of market it is good for any market to be competitive, because a competitive market is the one that has efficiency, and by efficiency we mean happiness for everybody, and I am just using another term for happiness, which is welfare. Okay?
That word has a bad, negative connotation.
Huh?
The term welfare has negative.
Okay, this is not welfare like food stamps or things like that. Okay, not that welfare. But why am I using this word welfare? Because United States is a welfare state. What do we mean by that? It means it wants welfare for all its citizens. Any democratic country, any democracy is a welfare state, which means the objective, one of the primary objectives of the government is to ensure welfare for its people. Okay? So that means if that is true, that means also the government wants competition in the market, And that kind of ties us back to where we started, you know, all the discussion about capitalism and free market and all of that. So that is primarily a reason that United States government wants free market, because if you have free market, then you will have competition. If you have competition, then the market will take care of itself and ensure efficiency. And if you have efficiency, then ultimately there will be welfare. So without the government stepping in as a dictator, without there being an interventionist type of government, you will still have welfare if there is proper working of competition in the market. Okay, now that brings us back to this question. Okay, so one more point, that is, so we said perfect competition is competitive and competition is good. Then why did we say that all other markets were less efficient than perfect competition? Do you remember? In monopoly and monopolistic competition, when we did those, we said that in the long run, those markets are less efficient than perfect competition. Why did we say that? And I remember I made you write that.
You want the 3 reasons?
Which 3 reasons?
Standardized product.
No. Those are characteristics of the market. When we drew the diagram for monopoly and monopolistic competition, and I remember precisely that I made you write down that this is the reason why these 2 markets are less efficient than perfect competition. Somewhere in that diagram you must have written. Can you remember? Why is monopoly and monopolistic competition, why are those markets less efficient than perfect competition?
Because they don't break even and they don't have minimal costs.
Correct. So that means those markets end up supplying a quantity that is lower and charging a price that is higher than perfect competition. You must have written it somewhere in your class notes that any other market which is not perfect competition ends up producing an output which is less than perfect competition and charges a higher price for that same output. If you compare in that diagram, your Q in monopoly or monopolistic competition was less than the Q of perfect competition, Q or Y, whatever you have denoted it by. And the price that was being charged, that was higher than perfect competition. Okay? If you go back and take a look, I am sure you will find it in your class notes. So that means, can we safely say that in a market where there is competition, or in a market which is closest to perfect competition, the price is likely to be lower than any other market? Can we say that? If you compare this market which is closest to perfect competition, then that market will have an output which is greater than any other market, and it will have a price which is lower than any other market, and that is why we are calling it the most efficient one. Yes? So that means competition in any market is good, and competition is good because prices that will be set in the market will be lower in a competitive market. So, okay, so even in the hospital market, if you have competition, then the prices are likely to be lower, and that is a good thing. So, we want competition in a market. Now, let us see that talking about this market, the hospital market, is there competition in that market? The answer is, for a long time in the hospital market, there was very less competition, and very less competition in terms of prices. So, price competition was very low. That means these hospitals did not want to compete with each other and definitely did not want to compete in terms of prices. Okay. There is some evidence that there was competition in terms of non-price factors. Non-price competition was there. What do I mean by non-price competition? Non-price competition basically means related to quality. Competition related to quality of care or quality of service that is delivered. But there was no, as such, no competition in terms of price. And once again, there is no theory behind that, there is empirics. If you read the lecture notes, you will see several papers have been cited who have looked into that, and they have seen that there was no competition in terms of price, and there was some competition in terms of non-price factors like quality of care or service. Now, the other features, the other smaller factors which kind of tells us that there was less competition or very less competition in the hospital industry is, first, the features of perfect competition are violated in this market. The first feature of perfect competition, large number of buyers and sellers. it is possible to have large number of buyers and sellers. Think about it. First of all, if a single hospital is catering to a very large market, right, only then you can have very large number of buyers in that market. But usually what happens in a hospital, it's a localized market. For example, you have 2 big hospitals in Springfield, but do you receive patients, do those hospitals receive patients from New York and from, you know, California and from North Dakota and from South Dakota? No, they are mostly catering to a localized market. People in Springfield or in the vicinity of Springfield. At best, people from Dallas or places like that, which are closer, right? So this market, the hospital market, is a localized market, and in a localized market, you can never have large number of buyers. It will be a finite number of buyers. So that means it is closer to monopolistic competition, but less close to perfect competition. In monopolistic competition, you had finite number of buyers and sellers, remember? Yes? So it's a localized market. In that sense, it is less likely to be perfect competition, but kind of more likely to be monopolistic competition. What else? The next thing in perfect competition was one homogeneous standardized product. Once again, in hospitals that is not possible. There may be some goods which are used in all hospitals, some products which are used in all hospitals, but the product, what is the product of a hospital? Hospital is not dealing with a tangible product, right? They are dealing with a service. So they are dealing with a subjective, intangible thing. And when they are dealing with a subjective, intangible thing, they are obviously differentiated because of the people who are delivering the things. So there may be hospital A and there may be hospital B, both catering to the same set of patients, but if they have different staff, different set of physicians, different set of nurses, right, different set of administrators, there will be difference in the quality of service that is delivered in hospital A versus hospital B. It cannot be homogeneous. If there are different sets of people working in the 2 hospitals, then the attributes of those people will be different, and hence the service cannot be identical or homogeneous. So it is non-homogeneous service. Once again, please note that in the hospitals, there may be, some hospitals may be kind of catering to certain group of patients due to the third party payers. For example, my insurance will send me to Mercy, so kind of I will be tied to Mercy. Even if I want to go to another hospital, I will not go to that hospital because I don't have financial incentives, or I don't have, you know, incentive enough to change my insurance and go to another hospital, right. So this is something like a patronization or loyalty, right, in some sense. It's not branding, but it's some sense of tying the consumer to a certain hospital. So also in that sense, it's not, there is some kind of, the consumer will not go to a different hospital, they will go to one particular hospital. That is also not a feature of perfect competition. The third feature of perfect competition was complete information. Patients have complete information about the hospitals. Is that true? No, right? Because at the end of the day, the patient is not consuming the hospital services, but the patient is first consuming the physician services. So physician is the agent between the principal, that is the patient, and the provider, that is the hospital, right. So the physician is in between, like the middleman. I don't want to use that word, but still, you know, you understand what I am trying to say. The physician is the one who kind of directs the patients to the hospitals. So there is absolute asymmetric information, incomplete information there, which is once again a violation of perfect competition. Okay. There is induction of demand for hospitals by the physicians. So the patients in that sense, they cannot, they do not have complete information about the hospitals. Okay. And the last point, in any question?
No.
Okay. Okay. in any perfectly competitive market, if there is a market which is perfectly competitive, in that kind of market, it is expected to see, you are expected to see that the consumers, in this case the patients, they will be extremely sensitive to price. If you remember, when we talked about perfect competition, we said that why are all sellers price takers? Because you are all selling homogeneous goods, the same good. So, if I go to you, you ask me for $10 and I know that she is selling it for $8, I will immediately go to her and all buyers will go to her. And if we get to know that she is selling for 7, then all buyers will rush to her. And so any undercutting in terms of price will not exist or will not sustain, because the person who has a higher price will not be able to get any buyers, and that is exactly what we mean by price competition, and that is exactly what we mean by price taking behavior. So, from the buyer's perspective, think about it. Now, talking about your elasticity, in perfect competition, buyers are, that means extremely price sensitive, isn't it? If there is even $1 decrease in price or $1 lower price with another seller, buyers will immediately move to that seller. Again $1 less, they will move to another seller. So, buyers in perfect competition are extremely price sensitive. You understand that, and that comes from price competition. Now, think about hospitals. Here it is very unlikely that the buyers will be price sensitive. In fact, buyers are price insensitive, or in other words, they have an inelastic demand. First, because the obvious reason that if somebody is going to a hospital, it must be something for which they absolutely have to go to a hospital. So, the need is a necessity, it is not an option. Hospital services may be a necessity for most people. So, obviously, their demand will be inelastic, and also think that there are still, it is true that many people in USA are uninsured, but also for the insured group of people, these hospital care, hospital services are usually high cost services, right? The cost will be high. So, that means there is a high possibility that that cost is getting covered by an insurance company or by the third party payer. So, the out of pocket payment of these buyers is likely to be lower in case of a hospital service, because usually hospital treatment is expensive, isn't it? So, usually it will be met by all those deductibles and all of that, the clauses of insurance, and it is quite likely that the risk burden heavily lies on the insurance company and not on the patient. If you end up getting admitted at a hospital and you stay there for 2 nights, it is most likely that if you have insurance, your insurance company is sharing the risk with you. So, you do not really care how much you are spending at the hospital, you only care about treatment at that point in time. So, your demand is inelastic, it is a necessity at that point in time, the treatment is your necessity. You do not care about the price, you are not going to go about shopping for the low price hospital. We do not do that. We usually do that while buying a car maybe, which is a luxury good. Where am I getting lower price? But if you need a surgery, you do not go price shopping at hospitals, that where is the surgery less, especially if you have an insurance, right? It will cover you anywhere. So, there are third party payers or insurance companies involved who are sharing major part of the risk, and by risk I mean the financial cost, and that makes the patients less worried about the prices or the price differences between hospitals. Okay. So, also in that sense you can see that this is not price competition or perfect competition, because in perfect competition we just said that patients or buyers would care about price differences, they would move to the lowest price seller. Here that does not happen. Okay. So, that means we can conclude by saying that in the hospital industry there is low degree of competition. There is low degree of competition. And that is also a reason why the hospital industry is inefficient, and in that sense it delivers less welfare to the consumers. Okay? There is inefficiency in the hospital system. But thankfully, with the emergence of managed care and with the expansion of managed care, there has been some improvement in the degree of price competition. As costs have become very high, nowadays it has been observed that there is some degree of price competition in the hospitals, okay? But not to the extent that we would really want, or not to the extent which would really make this market very efficient. So, at best we can say that the hospital industry is monopolistic competition, but we cannot say that this is close to perfect competition, okay, as far as the structure is concerned. Is that okay?
It's monopolistic, but it's not what?
It is monopolistic, at best it is closest to monopolistic competition, but far away from perfect competition. Now, one more striking feature in the hospital industry is this not-for-profit hospitals, right. So, we said 60% are those private not-for-profit hospitals. Now, in any other market, in any other industry, if it is privately owned, then you know that any private business operates for profit motive, right. Those are the three objectives of any businesses: profit maximization, cost minimization, revenue maximization or output maximization. Those are the objectives, right. Then why is it in this hospital industry we have something which is very different, which is not for profit hospitals? That means they are not driven by profit. First of all, what do we mean by not for profit hospitals? What are not for profit hospitals? How do you define them?
They don't have to return an investment to shareholders?
Correct. So, that means those hospitals are not funded by shareholders. They do not sell their stocks in the market and raise the money. Okay? They do not sell their shares to the market, or in other words, they do not have any shareholders, and the hospital administrators are also not shareholders of this hospital. So, that means if at the end of the day these hospitals have some residual earning, if they have some profit, then that does not get paid out as bonus and dividends to these hospital administrators. Okay? And mostly these not-for-profit hospitals, and how do they get the money? How do they get the money? Because obviously they have a cost of operation, right? They have operating costs. Charity, donations. They mostly run based on donations, or sometimes also based on aids from private individuals, or sometimes from local governments or state governments. Okay? They have very less federal funding, but they may have some federal funding also, but mostly they are run through aids and they are run through donations. Okay? And this feature is very common in the hospital industry, specifically for three reasons. Okay? Why is it so common? Why is it so popular, this structure, not-for-profit operations or not-for-profit hospitals? It's very common here because people have in general, like we said, you know, people in the sense patients, they already have asymmetric information. They already have incomplete information about the hospitals, right? So, if they know that one person is operating for profit versus another person who is not operating for profit, it is psychologically more likely that we as patients, we like to believe someone who says that I am not operating for profit. So, since there is asymmetric information, there is incomplete information in this market, the patients are likely to entrust their faith, they are likely to put their faith on someone who says who is not operating for profit, on the not-for-profit hospitals. And hence, the not-for-profit hospitals are likely to receive larger volume of patients or larger volume of consumers. Okay? That is one thing. Secondly, once again, this is not theoretic, it is observational. It has been observed that these not-for-profit hospitals are the ones who put in more effort and put in more money on things like, you know, research and development, in treating patients without insurance, that means providing free care. They have more public health initiatives. So, that is also a good thing for these not-for-profit hospitals, and that is why they are successful in the hospital industry. And last but not the least, in these not-for-profit hospitals, the physicians have a better control, or in other words, the physicians have their vested interest. Because if there is a hospital which has shareholders, shareholders will obviously, step in every time, they will intervene every time, and they will look at the balance sheet of the hospital because their money is invested in the hospital. So, there will be more surveillance or monitoring by shareholders. But if there are no shareholders, then kind of the physicians are the bosses there, right? And the physicians will be able to control what kind of other inputs are used in that hospital, because in a hospital, a physician is an input, right? For running the hospital, you need physicians, but you need several other inputs also. You need medical technology, you need nurses, you need other medical staff, right? And it's kind of a pyramid structure where the physicians are at the top, isn't it? So, if they are not monitored by anybody, if there are no shareholders, and the hospital is running based on donations, then this physician has more control over the mix of the other inputs that are used. And by inputs here I mean other things that are necessary, other resources that are necessary to run the hospital. So, there is also vested interest of the physicians which pushes the hospital industry to be more inclined towards private non-profit structure. Okay? Fine. But unfortunately, when some researchers kind of compared between the not-for-profit and the for-profit private hospitals, they do not see much difference in the nature of their operation. That means at the end of the day, all hospitals have some residual earnings. Whether they are run through shareholders' money or they are run through donations, all hospitals end up having residual earnings, or in other words, the actual profit margin of all hospitals are likely to be same in terms of real dollars. This has been observed. So, if that is true, now not having shareholders becomes a problem, right? That means nobody is looking into the balance sheet, nobody is trying to see what is the residual earning at the end of the day. Do you see what I am trying to say? So, if there are shareholders and if they are tracking the residual earnings, then they will also have some say in how those residual earnings are to be distributed. Some will be given out as bonuses and dividends to the shareholders, and maybe another part will go back into making improvements to the hospital, in the quality of the hospital. But here there is nobody who is, there is no surveillance of the hospital, the balance sheet of the hospital. So, even when they are earning profit, there is a problem in how that profit gets reinvested or how that profit gets plowed back into the hospital for its betterment. So, that becomes a problem in that case, because they both have similar kind of profits, and that has been observed. In real dollars, the profit margin is almost the same. Okay? So, that means we can say that even when they are called the private not-for-profit hospitals, they are still pretty much being run due to the profit motive. So, all not-for-profit hospitals still implicitly underlying there is the profit motive. They are all earning profit. Okay? It is not true that they are having zero profit or anything like that. So, that means profit maximization is still the motive of these not-for-profit hospitals. Okay. Now, this profit maximization, this takes two, and this we will end here with this last discussion. This profit maximization takes two different forms in these not-for-profit hospitals. You are able to see that motive in two different forms. The first is utility maximization. So they are actually maximizing the profit, but it is under the garb of utility maximization. Okay? And the other one is physician control.
Is this still non-profit or?
Not for profit. Yes, we are specifically talking about not for profit. So we just said that even the not for profit ones are actually governed by the profit motive, but that profit motive kind of takes two different proxies, or it gets hidden under these two things, that is utility maximization and physician control. Okay? So this kind of, you see this kind of stuff, you see this kind of behavior in the not-for-profit hospitals which are being run by a set of health administrators. And these health administrators are not essentially the physicians. Okay? So they are run by health administrators. Now by utility of the health administrators, what do I mean? They are trying to maximize their own utility, and this utility are both monetary, that means their own financial gain, how much salary they get, okay, or what financial benefits they get out of the hospital, plus some non-monetary benefits. And by non-monetary benefits, I mean some prestige or honor that is related to their designation at the hospital. So they are trying to maximize their benefits, and these benefits are not just the monetary benefits, but they are also the non-monetary benefits, something like prestige, honor, and so on and so forth. Okay? And in order to maximize both jointly, what these people will do, the decision makers or the hospital administrators in these people, they will drive up the quality. They will try to improve the quality of the hospital. Okay? They will try to improve the quality of the hospital. And by improvement in quality, I mean they will have better technology, better staff, okay, more operation theatres, things like that. Okay? Better healthcare professionals will be hired. And why do they do that? Because please note that we said that although there is less degree of competition, but some amount of competition is still here, right? And the only way that hospitals differentiate themselves from each other is through this quality aspect. So while they are driving up this quality, it is also taking the costs higher, but at the same time they are also getting more patients. More patients implies higher demand. Higher demand implies higher quantity. So they are able to cater to a larger share of the market by doing that. And by these costs, by this cost, I mean the operating cost. I am not talking about the price here. Equilibrium quantity. By equilibrium quantity, I mean how many consumers or what share of the market they can cater to. So eventually it is coming back. If you get more people coming to your hospital, you will make more money. So that's why we said that it is ultimately profit maximization, but they like calling it utility maximization. That means they are maximizing their own personal benefits. But even when they are maximizing their own personal benefits, they are actually going back to the final objective or the overall objective of utility of profit maximization and making more profits. Okay? And the last one, which is physician control, this is different from utility maximization because this kind of behavior we see in hospitals which are private, not for profit, but the physicians are the decision makers in those hospitals. So in other words, it is a physician-owned hospital. And most likely, these are not staff physicians. These are not the physicians who are employees of the hospitals. They are not employed by the hospital, but these are private practicing physicians who can refer patients to these not-for-profit places. So they have the right to admit patients in these hospitals, and hence they have vested interest in the operation of the hospital. But it is still private and not for profit. Okay? But the physicians are once again at the top of the pyramid. That means they are the decision makers. So what will these physicians do? Will these physicians have any incentive in hiring better healthcare professionals or any of that sort? Will they bring in more people, more staff physicians? Will they encourage the hospital to hire better physicians? No, because that will be direct competition. Instead, what will they want? They will direct their patients from their private practice to these hospitals. So in that way, they will ensure that demand increases, correct, in the hospital, because they will direct patients there. And that increase in demand will not be, just absorbed by hiring more physicians there. Instead, that increase in demand will just be absorbed by increasing the capacity of the hospital, not the quality. Increasing the capacity. By capacity, I mean number of beds, maybe number of operation theaters and things like that. That is what you see, right? You have experience in the real world. So not necessarily better people will get hired, not necessarily better technology will come into the hospital, but just that there will be more place created, there will be more beds created, more operation theaters, more surgeries taking place in the same day, right? They will just work towards building more capacity.
Would
Okay.
their profits be more maximized by the tax exemptions that they receive for being a non-profit as well?
Their profit will be maximized by the fact that there are more customers, there are more patients going there. So if more patients go there, obviously revenue will be more. If revenue is more, then profit will be more.
So if they don't pay taxes, wouldn't the profit be more as well?
When they don't pay taxes,
For being a non-profit hospital, they get tax exemptions?
they get tax exemptions, right, yes. But that is true for both cases, right? Here we are specifically talking about the not-for-profit people. So that is true for both.
Non-profit hospitals get more tax exemptions than hospitals?
Yes, but here we are not talking about for-profit hospitals. We are talking about not-for-profit hospitals, but we are saying that the not-for-profit hospitals ultimately also have the profit motive. So when you are talking about tax exemptions, that is true for both cases.
Gotcha. So you have an increase in QE for both
Yes,
the demand.
but how that increase is handled is different.